Okay. Right. So hi everyone and welcome and thanks for joining us today. All the panelists and all the speakers, all the experts and all the audience, the delegates that have joined us today. This is something that started about 4 or 5 years ago. We were wondering whether we should have an Indian consensus or not. There are so many international guidelines, the Sogi-Urakan guidelines on PMP and mesothelioma, the ERAS guidelines, and now the HIPEC consensus. Many European countries have the guidelines. There are Canadian guidelines, there are Brazilian and Chinese guidelines. So what are we going to achieve by adding one more guideline to it? And there were several reasons why we wanted it. One is for colorectal and gastric cancer, there are no international guidelines. And many of our oncologists still do not believe in surgery for these tumors. So we thought having a consensus would be a good place to start. And then if you've attended our meetings, there is always a pattern of questions that people in India ask. And there is not much evidence for most of these questions. So we thought we could have a consensus on some of these questions that are not covered by the existing guidelines. And this whole project really received a boost when Somshekhar and ISPSM agreed to join hands with us. And since then, it's been 2 years of lot of hard work from everybody. So let's hear the results. Dr. Somshekhar, would you like to say anything?
Thank you very much at the outset. Thanks Martin and Oliver to agree to join. I know an Indian consensus would not interest you when you yourself are author of international consensus, but it acts, it gives a very useful inputs for us. But I have to at the outset congratulate Aditi. This was her brainchild to bring it. She has put a phenomenal amount of effort. And I'm amazed at the energy she put into this, and great work from all the youngsters, Vivek, then Geetu, the entire group. They relentlessly worked it. This is one of those work where they do all the work and you take credit. As a boss, all of us know it's our residents, colleagues who does the work, and we travel world showing their work, and then we put our name. And sometimes you feel guilty that it's a department work, you contributed lowest, but you are roaming around. But full credit to Swapnil and the entire team. It's awesome actually. The effort the youngsters have put is phenomenal. Actually, we thought we'll guide them, but over a course, me and Aditi learned from them with the hard work they did. But what is most important for India is, in India, there is a two group. One who strongly believe in PSM and its work, and there is one big group of medical oncologists who don't believe in that. But when it is for their family and relatives, they would always find me, Aditi, Rohit, Ashwin, and all of us to make sure we would do HIPEC for them. So there's a lot of work we did, and fairly good participation is there. However, me, Aditi, Rohit, Ashwin, Dev, and Ramkrishna, Sanket tried to incorporate a lot of medical oncologists, but you know that their participation was not up to what we really wanted. But in a survey, you can call everybody, you can take a horse to pond, you can't make it drink, but this is how it is. But the way it came is amazingly good because of beautiful work everybody has put. We are very proud that we have second, third generation India better than what me, Aditi, and all of us are. And PSM and society and their work is very secure in their young hands. So at this outset, I would just say this and welcome all of you, and hats off to you guys, juniors, youngsters who are better than us. The hard work we did, you didn't have to do. And thanks very much, and welcome everybody, and we will continue the program.
Okay. Thank you, Dr. Aditi and Dr. Somshekhar, for that introduction. I think we'll start with the presentations today. We have a total of 9 sessions, one on methodology, followed by 8 subtopics which were decided for the consensus. To the audience, I would request that if there are any questions or queries, you can enter it into the chat box or on the Q&A, and we'll put forward those questions to the experts as well as the presenters during the time kept for discussion. Without wasting any further time, I would like to invite Dr. Swapnil Patel to start his presentation on the methodology on how this consensus was conducted.
Hello, everyone. Is my screen visible?
Yes.
Yes.
Right. So just to give a brief glimpse into the methodology of our consensus exercise, so Dr. Aiti and Dr. Somshekhar have already given a good introduction into the rationale and why was the need for this entire consensus exercise. There are numerous international organizations have been publishing consensus guidelines after other. Sometimes we feel that there are lacunae in the technical specifications. Sometimes region-specific practical aspects are not covered by the already existing guidelines. Then if we stick to India per se, India is a heterogeneous country with a very large patient population. There are several factors which are unique to India and the management of PSM. India has a huge socioeconomic divide. There is lack of uniform state insurance schemes. Then the demographics are widely variable. There are lack of screening programs and established referral pathways, which often result in advanced cancers at presentation. Our patients are more younger and have aggressive cancer variants. And then there are lack of dedicated tertiary care cancer centers, which are actually few in numbers. So despite all these odds, there is a rising interest in peritoneal surface malignancies more than ever. And this dictates a need of uniformity in the management of several gray areas, which have various evidence in various stages of evolution. So the goals of our entire exercise was to provide treatment recommendations for malignancies which were not already covered by the existing international guidelines, and to provide recommendations for some unique our country specific problems, and then again to achieve consensus on some general and technical aspects of CRS. We employed the modified Delphi technique. It was a joint venture by the two leading PSM societies of the country, INDEPSO and ISPSM. So after the project was convened, a core group was formed, which consisted of 13 surgeons with at least 5 years of experience in the field of peritoneal surface malignancy. This core group was responsible for the literature review and framing questions. And then there was a review group who reviewed these questionnaires for the validity of the questions, for the validity of the responses, and the adequacy of the literature review. What we decided to choose when we were framing our questions was to cover those aspects which were less often talked about. Those areas of management which are already well covered by the existing guidelines, we chose to delve less into them. So as we can see, eventually we had 8 working groups dealing respectively with the colorectal peritoneal metastasis, gastric cancers, advanced epithelial ovarian cancers, peritoneal mesotheliomas, pseudomyxoma, the ERAS. Then we also included 2 newer sections, minimally invasive surgery, and then a section on technical aspects of CRS. The existing guidelines on each topic were reviewed by the respective groups. Some questions which are already extensively addressed were not addressed in this current consensus exercise. A literature search was thoroughly performed on each of these issues chosen by the core groups for all the 8 areas. In accordance with the Medline and the MBase databases, we chose to consider the literature review from 1990 till 2022. So India being a heterogeneous country, we wanted to get a perspective from the entire portion of the country. And we had a mix of GI oncologists, gynec oncologists, and surgical oncologists from the entire representation from all across the country in various sectors of the cities. So this exercise took nearly 18 months. It was started in October 2022, and now it was finished in March 2024, and here we are with the results. So as we can see, a total of 62 panelists were invited to vote once the initial exercise was complete, of which more than 90% agreed to vote. And the good thing was that the number of respondents was pretty high, more than 90% in both the rounds. We chose to have just 2 rounds. We did not have the 3rd round. And if we go on to see the response rate to the questionnaires by the invited panelists, there was a good response rate across all the 8 subtopics. And to just point out, the least response which we observed was for the area of minimally invasive surgery, where the response rates in each of the 2 rounds was around 77%. To achieve a consensus, we chose that any option was to receive more than or equal to 70% of the votes, or in case of a multiple choice question, at least one option had to receive more than or equal to 70% of the votes. To achieve a strong consensus, any option receiving more than or equal to 90% of the votes was labeled to be having a strong consensus. For each question, at least 80% voting was required for it to be considered valid. And for every section in a particular subject, required at least 80% of the questions with the valid voting, that is 80%. And as already said, only 2 rounds of voting was planned. And if we see, with respect to the completion rate of across the 8 subsections, the completion rate of the various questionnaires was very good and more than 80% in most of the areas. If we see the consensus achieved with an overall perspective, what we can see that there were 262 questions to vote on for all the panelists. For in the round 1, at the end of it, nearly 37% of these questions could achieve a consensus. Then those who did not achieve a consensus were put to vote in round 2, when again 42% of the questions achieved consensus. Those which did not achieve consensus were left and labeled as having achieved no consensus at all. So overall, 80% of the questions did achieve consensus, and we had nearly 23% of the questions achieving a very strong consensus. So just to conclude and summarize that the idea of the entire exercise was to bring around some homogeneity in the management practices across diseases, across regions in the country, which are very diverse, both with respect to the diseases and with respect to the management practices area-wise. We feel that this entire exercise would be a useful resource for the surgeons in our country, and even for other regions and other countries which have a similar demographic and socioeconomic background and have started treating peritoneal malignancies. So with this, I would like to hand over to my further participants to give a brief glimpse into the section-wise topics. Thank you.
Thank you, Swapnil, for that wonderful presentation on the methodology on how the consensus was collected. We move on to the presentations proper. The first presentation is by Dr. Deepti Mishra on the general considerations and technical aspects of cytoreductive surgery. A reminder to the audience, if you have any questions, please put it on the Q&A box. And we will put forward the questions to the experts in the time that we have put aside for discussion. We have a QR code that is on display. This can be scanned to get a quick view of the algorithms and also the consensus statements of each of these subtopics. Dr. Deepti?
Yeah, good evening, everybody. Am I audible? My slides are visible?
Visible and
you're audible, ma'am.
So coming to the technical questions, here myself, my colleague Dr. Niharika and Dr. Aditi, we have worked on it. So why the consensus was required on this was because the peritoneal surface oncology is growing as a very broad specialty. And we find that many groups are joining in this peritoneal surface. So there is a requirement of consensus statement for some basic principles of cytoreductive surgery that could be applicable in all category of patients of undergoing CRS, and to create a reference source for the surgeons from different backgrounds. So I'll not go into the detail of the methodology. We have made 2 categories basically. One was in which 10 questions were there in category 1, radiological, pathological, and quantitative prognostic indicators. And in category 2, which was dealing with the technical aspects of the cytoreductive surgery, around 28 questions were there. Coming to the prognostic indicators, radiological and pathological. So from the beginning only, when we found that when the majority voted, we could not find a consensus for the type of imaging should be done for these patients and the interval between the imaging and the planning of surgery. So with these 2, we could not find the consensus. Regarding the pathology, this is the one question where 100% people, 100% panelists voted for a need of an experienced and specialist pathologist. And if it is the pathologist is not available, at least a second opinion should be obtained from a referral center, the center who are performing regularly the peritoneal surface oncology. Detailed report should be given. It should not be just in a section of the peritoneum. It should be the evaluation fully, the response of the neoadjuvant chemotherapy, evaluation of the resected viscera and the nodes, and detailed peritoneal involvement. We could achieve the consensus on these 4 points. Sugar-Baker PCI was voted by the majority as a scoring system to assess the peritoneal disease. And everybody, most of the majority found that radiological PCI should be calculated before performing any CRS. Promise internet application could not find a consensus in our group, and we could not find a consensus here. What are the absolute contraindication for the cytoreductive surgery? Multiple options were given. Out of those, majority selected the involvement of the bladder trigon, infiltration of the pancreatic head, and the diffuse mesenteric retraction should be taken as a contraindication. And the goal of cytoreductive surgery should be either CC0 or CC1, depending on the pathology. Coming to the general principles of cytoreductive surgery, here, whatever is the pathology, and when the plan of cytoreductive surgery is done, then incision should be from the xiphi to the pubic symphysis, and the approach can be either extraperitoneal or transperitoneal. So we could achieve a consensus here. All the previous scar, it can be diagnostic laparoscopy scar, previous surgery scar, while removal of the primary tumor, all the abdominal scars should be removed. We got a consensus here. Regarding the two-stage cytoreductive surgery, it can be performed, but in a very selected group of patients, it should be done. Whenever we are planning a two-stage procedure, the question was asked that what should be ideal interval? The majority voted 3 months should be an interval. And when should we do a HIPEC? So after the second procedure, if CC0 or CC1 could be achieved, the majority voted it should be done after that. Type of electrocautery, there were many options here again. So, but we could not achieve a consensus which particular type of electrocautery we should use. Should we use a smoke evacuator? Again, we could not find a consensus here. Coming to the diaphragmatic peritonectomy. While doing diaphragmatic peritonectomy, if there is a rent, when it should be sutured, so majority voted it should be sutured immediately, and whether the thoracic cavity should be perfused with while doing the HIPEC. So it should only be perfused if directly there are the pleural deposits were there. Then in that case only we found a consensus that it should be perfused. Placing a routine chest tube should be done or not. Again, we could not find a consensus here. Routine placement of chest tube could not find a place here. Regarding the visceral resection, so what all major resection was voted by the can be done during the CRS procedures were, we have given many options. Out of those, the majority have chosen that distal pancreatectomy can be done. Hepatic resections like non-anatomical and the sectionectomy should be done. We can the majority opted for the subtotal gastrectomy, total colectomy. Here we can see total gastrectomy, total pelvic exentration, and pancreaticoduodenectomy could not find consensus by the majority. Need of splenectomy. If the direct involvement of splenic hilum is there, or if the capsular deposits are there, for which we need to remove the spleen, should be done to achieve a CC0 or CC1. Here, cholecystectomy, we could not, because exactly we got a vote of 70%, so that we could not get a clear guideline, clear consensus here that whether routine cholecystectomy should be done or not. For appendicectomy, the majority voted if there is direct involvement of the appendix or mesoappendix, then only the appendicectomy should be done while doing CRS. Whether we should do a rectal resection while doing pelvic peritonectomy. So if there is direct involvement of serosa or mesentery, majority voted we could achieve a strong consensus on that majority voted, then only we should do a rectal resection. Coming to the stoma formation. So diversion stoma, whether we should do a routine diversion stoma and what should be the type of stoma. On both the question, we could not achieve a consensus, but here we had a consensus. If suppose stoma has been done and after the cytoreduction surgery and HIPEC, when to reverse it. So majority voted it should be reversed after the 3 months of the period. Coming to the performing a mesenteric peritonectomy. So the combination of method, which can be a combination of blunt dissection, sharp dissection, electroevaporation, could find a consensus. There is not a preferred one technique here. Routine removal of gastroepiploic arcade, even if there is no involvement, could not find a consensus, but only it should be resected when there is a direct involvement by the tumor. Certain target organs like falciform ligament, umbilical round ligament, lesser omentum, should it be removed or not to be removed, irrespective of the presence of visible disease. In these 3 categories, in serous ovarian cancer, PMP, and mesothelioma, only could find a strong consensus to be removed routinely. Extensive intraperitoneal lavage, find a consensus. It should be given to all the patients after the tumor resection. Prophylactic ureteric stenting should be done only in a difficult situation like extensive disease in the pelvis or prior pelvic surgery. We could find a consensus here. Re-resection, routine re-resection of the previous anastomosis should be done or not. So here, only in the case of anastomotic recurrence, or if it is required to achieve a CC0 resection, this re-resection of previous anastomosis should be done. It could find a consensus here. Use of mesh for different type of hernia which can present during the surgery, could not find a consensus here, although options were many, but we could not find a clear-cut consensus here. So to conclude, I would like to just conclude it here like that it is an effort of its own kind to create a consensus among Indian surgeons managing peritoneal surface malignancies of different types. Consensus reached are, whatever consensus we have reached are of very practical clinical utility and applicable to all categories of patients undergoing cytoreduction surgery. Overall, it indicates a need of framing an international consensus to standardize technical aspect of CRS by expert surgeons. Thank you very much.
Thank you, Dr. Deepti, for the presentation on general considerations. We will move on to our next presentation, which is on ERAS in cytoreductive surgery by Dr. Geeto Bandoria.
Are my slides visible?
Yes, they are.
Yeah. Hello, everyone. I'll be speaking about the ERAS protocol consensus that we got in this exercise. So enhanced recovery after surgery protocols have brought a paradigm shift in the perioperative care by re-examining the traditional perioperative practices and replacing them with evidence-based best practices. These protocols are comprehensive in their scope, covers all the areas of a patient's journey from the surgical planning until they have completely recovered. There are 4 primary aims of ERAS: faster functional recovery, reduction of surgical complications, reduction of hospitalization, and finally a reduction in the readmission rates. There are several ERAS guidelines available across different surgical disciplines, including cytoreductive surgeries. We had performed a survey among Indian CRS HIPEC surgeons sometime back, and this survey questionnaire was the template for our consensus exercise. This was a two-round consensus using Delphi method. The questions were divided into 4 groups addressing prehabilitation, preoperative elements, intraop, and postoperative elements. We achieved 100% questionnaire completion by the second round, and we could get consensus on 28 of the 30 questions that were asked, including strong consensus on 5. The first question that was asked was, should ERAS protocol be part of a CRS HIPEC surgical unit or team? Although there was no consensus on this, because not a single option was agreed upon by more than 70% respondents. However, cumulatively, almost 87% panelists felt that yes, it should be part of the team, whether before or after CRS HIPEC protocols have been established. Moving on to the prehabilitation, nutritional assessment at the time of surgical planning is essential and should be performed for most patients. Alcohol and smoking should be completely stopped. This was a unanimous polling and thus a strong consensus. Cytoreductive surgeries and HIPEC are radical, ultra-radical procedures with their morbidity. So a patient and their caregivers both require not just physical, but a psychological preparation. Thus, a psychological evaluation and counseling should be performed before surgery. Some form of exercise should be advised for most patients, irrespective of at what point of time they are going to be operated. Moving on to the preoperative elements, breathing exercise in the form of incentive spirometry should be advised to most patients. Similarly, anemia should be identified and actively corrected, either by blood transfusion or by drugs, depending on the time available. Moving to mechanical bowel preparation, nearly 80% panelists felt that yes, it should be performed for planned rectal resection or left colonic resections only. Only the left colonic resection part is in contravention to the IRAS international guidelines as per the IRAS Society. Otherwise, yes, mechanical bowel preparation is recommended for rectal resections. Regarding the modern fasting guidelines, most panelists felt that yes, only a 6 to 8 hour fasting is needed for solids and just about 2 hours for liquids. Carbohydrate loading should be performed if pre-mix carbohydrate solutions are present like ClearFast, then they should be used. Otherwise, some local alternatives could also be tried, but only in non-diabetic patients. Moving on to deep venous thrombosis prophylaxis, it should be initiated preoperatively by pharmacological agents like low molecular weight heparin, continued intraoperatively with pneumatic compression devices, and continued postoperatively up to 4 weeks after surgery. Regarding prophylactic antibiotics, most panelists felt that the antibiotics should be used as per the institutional policy rather than some specific antibiotics only. Coming to the surgical preparation of the skin, chlorhexidine alcohol solution is the preferred agent rather than iodine-based solutions only. Moving on to intraoperative elements, when asked about what should be the analgesia approach, most panelists felt that there should be a multimodal analgesia plan, wherein some local blocks like thoracic epidurals or nerve blocks and some opioid-sparing agents should be preferably used rather than just epidurals or just opioids. The fluid management protocol should be goal-directed, where the goal should be monitoring of different pressures depending on the team's protocol, and combination of crystalloids and colloids should be used. There was a strong consensus on this question. Operating rooms are conventionally colder places, thus monitoring the temperature is extremely important for achieving optimal outcomes. There was a strong consensus on this also, that normothermia maintenance is extremely important. Nausea vomiting is a common postoperative complication, thus it should be actively worked on, and prophylaxis should be done using multiple agents. Postoperative care, where should the patient be cared for after the surgery? Most panelists felt that patient would go to ICU. However, the ICU stay should be kept to a minimum. Postoperative ventilation, no single technique of ventilation was agreed upon. However, the panelists consented that yes, it should depend on multiple factors and comorbidities of the patient's performance indexes, and that's how one should be monitoring these patients. There was a strong consensus on this. Postoperative feeding plan is to start with enteral feeding and gradually move on to oral feeds. However, parenteral nutrition is allowed in case the patient is taking longer. Again, a strong consensus was achieved. Regarding drugs that could be used to hasten return of bowel activity to allow feeding, no consensus was achieved on this. The only second question, in the entire exercise. Post-operative ambulation should be attempted as early as possible and feasible, depending on the patient's recovery. Intraperitoneal drains, most panelists felt that yes, they should be used for all the patients. Coming to the urinary catheter and nasogastric tubes, most panelists felt that they should be removed as early as they are feasible, again, depending on the patient's recovery. Patients should be discharged as early as is feasible, depending on both the condition of the patient and the administrative factors, whether they are from the same station or some outstation and other economic factors. There should be regular audits into whether the adherence to these protocols are being met or not. Otherwise, we would fail to identify if we are going the right way. This is a snapshot of the entire guidelines. So just to summarize, except two questions regarding ERAS being part of the CRS IPEC protocols and bowel stimulants, we could get a consensus on all other 28 questions. So to conclude, most of the ERAS CRS IPEC international recommendations were agreed upon, except the mechanical bowel preparation for the left colonic dissection. Thank you.
Yeah, thank you, Dr. Gitu, for the presentation on ERAS. Next, we'll have the presentation on the minimally invasive surgery. Kalpesh, can you share the recording, please?
Good evening, everyone. I will be discussing the consensus statement on minimally invasive cytoreductive surgery in the management of peritoneal malignancies. Cytoreductive surgery is conceptually an open surgery with a large incision from the xiphisternum to the pubis. Minimally invasive CRS is relatively a new concept, with recent publications being mostly retrospective and heterogeneous in character. The criteria in most of the publications have been a good histology and low PCI, that is, a PCI of less than 10. The methodology has been discussed in detail earlier. We had 2 members in the core group and 2 in the reviewer group formulating and verifying the questions. The voting panel consisted of 56 surgeons. The questions were divided into 2 main topics: staging laparoscopy and minimally invasive cytoreductive surgery. There were a total of 24 questions that were put to vote, with a 83.9% response rate in the first round and 92.86% in the round 2. The completion rate was over 80% in both rounds. The initial few questions were on staging laparoscopy. 77.36% of respondents concurred that a staging laparoscopy is indicated in a selected group of patients planned for cytoreductive surgery after 2 rounds of voting, with consensus obtained that staging laparoscopy can be performed just prior to commencing CRS or as a separate procedure depending on circumstances and resources. The next few questions were on technique of staging laparoscopy, with no consensus being obtained after 2 rounds of voting with regard to the technique of entry while performing a staging laparoscopy. However, 78.72% agreed with the periumbilical region being the site of initial entry and camera port, with the Palmer's point and Li Huang point being alternatives if there was involvement of the umbilicus or previous laparotomy scar. Consensus was obtained that all working ports must be placed in the midline when possible. 72.92% of the respondents agreed that the wide resection of port sites must be performed during cytoreductive surgery. 89.36% of the respondents agreed that an intraoperative recording must be performed for future reference. There was no consensus after 2 rounds of voting on the question whether a staging laparoscopy can be avoided if an MRI has been performed. We probably will be in a better position to answer the same question after the results of an ongoing RCT trying to answer the same question is published. Moving on to the section on minimally invasive cytoreductive surgery, consensus was attained that minimally invasive cytoreductive surgery could be performed in selected patients by surgeons with necessary MIS skills and experience with open CRS. 76.47% agreed that the minimally invasive approach has limitations such as lack of tactile sensation, there was a risk of missing disease, it was time consuming and challenging technically. Strong consensus of 91.49% was obtained that all patients considered for minimally invasive cytoreductive surgery should undergo a staging laparoscopy prior to the procedure. After 2 rounds of voting, consensus was obtained that the staging laparoscopy can be performed either in the same setting or as a separate procedure. Strong consensus of over 90% was obtained that the laparoscopic CRS must not be performed if there was incomplete evaluation during diagnostic laparoscopy. 84% agreed that minimally invasive cytoreductive surgery must be performed only in patients with limited PCI, that is PCI of less than 10, with favorable distribution of disease, with over 97% concurring that histological confirmation is a prerequisite. A PCI of more than 10, major prior surgery, large abdominal masses, gross diaphragmatic involvement, and multifocal mesenteric lesions were all considered absolute contraindications to minimally invasive cytoreduction. There was no consensus obtained on the preferred technique of HIPEC after minimally invasive cytoreduction. There was a consensus of 78.43% that minimally invasive synchronous resection of colorectal primary along with minimally invasive cytoreduction can be planned only in centers of expertise if PCI is less than 10. A mini laparotomy was the preferred site of specimen extraction. 76.6% also agreed that a mini laparotomy could be performed in selected patients for the inspection and palpation of small bowel and its mesentery during minimally invasive cytoreduction. There was no consensus on performing minimally invasive cytoreduction in patients with aggressive histological subtypes such as poorly differentiated adenocarcinoma or signet ring cell carcinoma. There was no consensus obtained after 2 rounds of voting on minimally invasive cytoreduction after complete or near complete response after neoadjuvant chemotherapy in ovarian cancers. This is a summary of the consensus obtained. An algorithm for minimally invasive cytoreduction has been created based on the responses obtained. In conclusion, the consensus was in line with available literature, with the consensus being reached on staging laparoscopy as well as the patients who are eligible for minimally invasive cytoreduction. Most of the consensus was on the practical aspects as there was very limited data on minimally invasive cytoreduction, which is a limitation. Minimally invasive cytoreduction should be performed only in centers with experienced surgeons with expertise in cytoreduction and minimally invasive surgery.
Thank you, Vivek. That was a crisp and good presentation. Now, having kept the ball rolling, we know India is playing tough pitches in US for T20 matches, and so has been the topics that have been presented till now. Basic tough pitches where we would always want to, feel comfortable, play some, take some time, and spend some time to know what is going on, so that you can play well when you go to West Indies. Right, so we had good presentation from Swapnil, Deepti, Geetu, and Vivek. I would now request our international experts, Dr. Oliver Glihan and Dr. Martin, if you can opine your expert comments and throw light on any of those topics if you would want to.
Okay, so first of all, I would like to really congratulate all of you for this tremendous and very useful work. I think that such initiative should be performed in every country that develop the management of peritoneal surface malignancy, because it will be a very good tool to try to be as homogeneous as possible and try to define what should be performed and what could be performed in every situation. I have perhaps two comments. I was surprised to see that total gastrectomy did not reach consensus in combination with IPEC because, as you know now, performing IPEC in gastric cancer, we have into the literature and especially in France in our experience, some not level 1 evidence, but some evidence that it may help patients with gastric carcinomatosis. It was my first surprise. And my second surprise, and I'm a little scared, is to see that you reach a consensus to perform cytoreductive surgery by mini-invasive approach in colorectal peritoneal carcinomatosis. Even if it is for a selected patient, I think that it's even in good hands, even with experienced surgeon in laparoscopic approach. A big risk of not cure some patients that could be cured. But I begin, to be an old surgeon. And maybe I'm not sufficiently modern. But regarding what we are discovering during peritoneal disease from colorectal cancer, I think personally that it's still very difficult to evaluate the entire peritoneal cavity by a laparoscopic approach and to be sure that you do not let some disease after your surgery by an only mini-invasive approach. I think that probably in the future we will be able to apply this, but we need to make some more progress in the preoperative imaging, in the intraoperative imaging, in the techniques that allow to explore the entire abdomen. And I can tell you that for the moment, I will do my best not to diffuse this message, especially in France.
Great. Martin, you want to tell something?
Yeah, thanks very much for giving me the opportunity to follow those extremely interesting and thought-provoking presentations. I have a couple of remarks, not criticisms, just remarks with regards to the methodology. So first of all, I think it's a magnificent practice survey, but no guidelines. So here we have to distinguish. It's a practice survey. What is done and what you prefer to do, don't get India. You chose for most questions the categorical yes, no. What you would do if you marry somebody, do you want to marry somebody? This is a yes, no question. For more difficult questions, it might be easier to reach consensus if you take Likert scale, for instance, 4-time Likert scale to give the options might be done or should be done, which is not quite the same. This would have potentially enabled an easier choice and also to come easier to consensus. You failed for some items to reach consensus for this one. Second, 2 rounds means only 1 round with feedback of the other panelist responses. So if the main aim would have been to reach a higher consensus, you could have gone for a third round, and you put the consensus bar really high. Yeah? So it's totally acceptable to accept the consensus at 70% threshold. But these are just remarks to defend you for the points where you didn't reach consensus. Huh? So, and my main point, which is rather to be considered as an invitation to you. So you nicely highlighted also some discrepancies, with for instance, ERAS recommendations, but you also mentioned other national guidelines. So I think it would be extremely interesting to put together a table, summarizing especially discrepancy between different national guidelines and recommendations, and then attack together the question why. Why do we have those discrepancy? Is it lack of evidence or perceived lack of evidence? Is it that people think it's not feasible? Is it logistics strains or costs which are associated? So I think it would be extremely important to attack the why, because this information would also enable us, and hopefully together with some of you, to update the guidelines, like for instance the ERAS guidelines, which are too extensive, which were too ambitious. And here we clearly need information why people are reluctant, for instance, to refrain from not doing bowel preparation for colonic resections. We need to know why some other things are difficult to be acceptable in India. And I think we could this also do together in the international setting in order to make the future international guidelines even better, because it's good to have guidelines, but we need to have guidelines which are accepted by the community, because otherwise they are not worth anything. Really, my congratulations, magnificent work, and very concisely presented. Thanks very much.
Thank you to both of you for your most, picking up those nukes and corners and making those things very much obvious. I would just ask our national experts just to put on few, and then we'll go back to Aditi ma'am. She has raised her hands. Before that, I will just ask Ramakrishna sir or Sanket Mehta sir if you have anything to comment on.
Rohit, I'll speak in the end. I already have
Okay.
some conclusion remarks.
Fine, sir. Sanket sir?
Yeah, so very concisely presented. Thank you, the presenters. I think, one of the things that surprised me as well was the uniform enthusiasm for minimal invasive cytoreductive surgery, which is very surprising. I myself am not a big proponent of that, although I know my colleague Vivek really thinks it's the future. And second thing is, again, the total gastrectomy. I think when we do CRS and HIPEC for stomach cancer, we do a total gastrectomy. So I think it's a little surprising that most people voted that we could not do a total gastrectomy with HIPEC. Apart from that, most of the things were pretty much what we anticipated. Again, I think the overall acceptance of ERAS protocols is very gratifying. Most people had consensus on most of the factors of ERAS protocol, which I think should be accepted everywhere. And let's wait for the rest of the results. Thank you.
Thank you, sir. Ma'am, you can go ahead, ma'am.
So I wanted to speak in defense of the minimally invasive recommendations. When we came up with this, it's because, why did we have this section? Because a lot of surgeons are fascinated by it and they want to do it. And sometimes you put questions to vote, hoping that the recommendation would be negative. But then, when you have a positive recommendation for something that you would personally not recommend, and the rest of the panel votes for it, and they have sufficient experience with cytoreductive surgery, there's nothing you can do. But of course, we will take a cue from this. And when we publish the results, we will put this all these points into the discussion. And regarding gastrectomy, I think it's they were talking more in combination with a total colectomy, and that's the reason why they were not thinking specifically of gastric cancer. They were not thinking of primary resection, but what visceral resections for peritoneal disease are acceptable. So I think those two points needed a bit of clarification. Thank you.
Great. Thanks, ma'am. Personally, for me also, one topic which is anyways going to be debated as far as PSM is going to be operated on is definitely about imaging. Oliver, sir, I just wanted to ask you what is the standard you would want to, if at all it is being set up for imaging in any peritoneal surface malignancy?
Currently, the CT scan remain important and should be still performed, I think, for every patient, as you mentioned in your guidelines, in your recommendation, in your survey, as and the combination of MRI appears to be really important. I think that performing both may really help to establish where is exactly the peritoneal disease into the abdomen, into the parietal wall. The combination of these two morphologic exams is more important in patients that receive previous surgery. When you have metachronous disease, when you had the previous surgery, it will really help you to locate it where the disease that is, and it will help you to perform a real adequate cytoreductive surgery, which is, as you all know, an absolute condition to get the better results. For the other functional imaging, PET-CT and the flappy tap, we need some more evidence, some more demonstration to incorporate probably them in the preoperative workup.
Great. Thank you, sir. I think there were a few questions that were put up in Q&A sessions, and most of them were answered. All our panelists are very active as well in the chats. They've completely answered all the questions. Having anybody there? No. Okay. So having played the tough pitches on USA, moving on to the organs now. I would now request the next series of presentations to be coming on. We have Vivekanand Sharma, who will be starting off with pseudomyxoma peritonei. Vivek?
Good evening, everyone. My name is Vivekanand Sharma, and I'll be presenting the results of our consensus in managing mucinous appendiceal neoplasms and pseudomyxoma peritonei. It is recognized that mucinous appendiceal neoplasms, or MANs, are rare, with a quarter of them developing pseudomyxoma peritonei, or PMP. While the real incidence in India is unknown, MANs can often mimic appendicitis and affect as many as 36% of appendicectomy specimens, which emphasizes the value of knowing management of MANs and PMP. We use the modified Delphi method in this exercise. 2 core members created the questions, which were reviewed by 3 others. 45 specialists participated in this exercise. 91% completed round 1 of voting, while 92% completed round 2. The results are being presented into 7 main categories. Preoperatively, 88% voted for tumor markers, serum CEA, CA19-9 and CA125 to be requested, and 85% felt a CT scan should be performed as baseline imaging. 87% felt a colonoscopy should be performed, and 74% felt in selected patients staging laparoscopy should be performed. 97% participants favored the SOGI 2016 classification for reporting appendiceal pathology. When a MAN is identified incidentally, on imaging, or intraoperatively, management depends on the presence or absence of perforation, involvement of appendiceal base, and evidence of any peritoneal disease. In incidental MAN, without any perforation or other abnormalities, 92% favored performing a radical appendicectomy involving removal of appendix with its mesoappendix. However, there was no consensus if peritoneal disease was suspected in such a scenario. 59% recommended a thorough exploration and referral to a peritoneal malignancy service after documentation of site and extent of disease. A similar recommendation was made by 74% alongside source control in perforated MANs with evident peritoneal disease. When MANs are identified after an appendicectomy, the management depends on their grade, their presentation, which may suggest their T stage, and staging evaluation. These are so likelihood of future PMP can be determined and proportionate interventions offered. When describing the pathology, we have used the SOGI classification system. For a non-perforated, low-grade or high-grade appendiceal mucinous neoplasm, without any evidence of other disease on evaluation, observation with periodic imaging and tumor markers were recommended by 72%. However, in a similar scenario with a LAM, if the margins were found to be positive, 74% advocated excising a cecal cuff or an ileocecal resection to obtain negative margins. 77% favored a prophylactic right hemicolectomy as a part of cytoreduction in HIPEC when a perforated or T4 ham was identified with involved margins. And 79% voted on similar lines in the presence of peritoneal disease. In the situation where non-perforated ham was found to have involved margins, or a perforated ham was identified with free margins and no other disease, a consensus could not be obtained. The management of mucinous adenocarcinomas of the appendix depends on their grade. For a non-perforated, well to moderately differentiated MAC, a right hemicolectomy was supported by 80%, irrespective of margin status. The same was recommended by 79% when a poorly differentiated histology was identified, again irrespective of margin status. 79% voted alike in a similar scenario if the primary was poorly differentiated MAC with signet ring cells. It must be emphasized that the consensus in these past scenarios with high-grade histology doesn't match the SOGI consensus where a prophylactic CRS and HIPEC was favored. A prophylactic right hemicolectomy as a part of CRS and HIPEC was supported by a strong consensus in perforated, poorly differentiated MAC with involved margins, while 77% voted for the same in a poorly differentiated MAC with signet ring cells irrespective of margins or perforated status. A strong consensus of 93% considered patient comorbidities and surgical risk, while 80% felt patients' education and understanding of risk-benefit scenario as important factors to be considered when managing these in the Indian context. In established peritoneal disease, our exercise looked at evaluating some specific scenario. In situation where total gastrectomy and total colectomy is necessary to achieve complete cytoreduction, a consensus supported it only in patients with low-grade PMP who have good nutritional and social support and face no cost constraints. These acknowledge the impact of such an extensive surgery on a patient. On the other side of the spectrum, when contemplating fertility preservation in a motivated patient with low-grade PMP, a strong consensus permitted it in an educated patient aware of the risk-benefit scenario who had grossly normal ovaries. Additionally, low pelvic disease burden was identified as an important consideration. When managing high volume PMP, a predicament comes up when complete cytoreduction is hard to achieve. A strong consensus of 95% chose maximum tubal debulking if CC0 or 1 was deemed impossible. a consensus was also achieved on debulking in symptomatic patients with poor performance status. This was permitted in all grades of pathology apart from poorly differentiated and signatoring cells. 82% felt HIPEC in the setting of tumor debulking was only suitable for selected patients. Another approach adopted by some is a two-stage operation. Now this has already been discussed in the technical section, but for PMP alone, 80% voted for such a procedure to be suitable only for selected patients in specialized centers. And 75% felt the first stage operation here should aim to complete cytoreduction in one compartment. A strong consensus of 95% suggested waiting for approximately 3 months between the two stages and HIPEC be added to second stage only. While 85% agreed that cytoreduction and HIPEC should be the standard of care for PMP, a consensus could not be achieved on the role of early postoperative intraperitoneal chemotherapy or EPIC, with 70% recommending it only in the context of a clinical trial. When dealing with concomitant extraperitoneal disease, 75% of participants advocated a CRS HIPEC as long as the disease remained stable on chemotherapy and suggested the use of systemic chemotherapy in unresectable high-grade disease or lymph node positive disease. When following patients up, tumor markers were recommended quarterly for the first 2 years and then half-yearly in both LAMs and MACs by the majority. However, there was no consensus on the policy of clinical review or the imaging protocol, highlighting the complex nature of these situations and the need for individualization of care. 72% of our participants opted for tumor markers, imaging, tissue diagnosis, and mutational analysis when evaluating a patient with suspected recurrence, and 77% voted to offer surgery in a recurrent but resectable disease for a fit patient. These charts show a summary of the recommendations from the consensus exercise. To conclude, in the incidental setting, our participants recommended the least invasive surgery that would ensure a negative margin and yet permit adequate staging. Our participants acknowledged the role of CRS HIPEC in established peritoneal disease, but adopted a pragmatic approach and stricter criteria for prophylactic cytoreduction and HIPEC. When dealing with these patients with mucinous appendiceal neoplasms and pseudomyxoma, sometimes different approaches need to be adopted. Decisions regarding these are better made by clinicians experienced in the care of peritoneal surface malignancy. Thank you for your time.
Thank you, Vivek. That was very well presented and very crisp as well. With such extensive, in-depth discussion on PMP. Now we move on to peritoneal mesothelioma. I would now request Dr. Ambrish Chatterjee to come up with the presentation. Dr. Ambrish.
Thank you. Just a minute. A very good evening to one and all. Just a minute, please. Is the slide visible? A very good evening to one and all. Hello?
Not yet, Ambrish.
No. It's
Meanwhile, please continue to put your questions on Q&A and chats. We will take them independently. Please go ahead, Ambrish. Your screen is visible.
Yeah. So this. Very good evening to one and all. I am Dr. Ambarish Chatterjee, and I'm here to present the INDEPSO ISPSM consensus on peritoneal mesothelioma. Why the consensus? Diffuse malignant peritoneal mesothelioma is a very rare and aggressive disease, and hence there are difficulties in conducting randomized controlled trials. In fact, there are none. These consensus are especially we conducted to identify issues particularly applicable to India, clarify the questions, and hence establish decision-making statements. Particularly in peritoneal mesothelioma, patient selection, extent of surgery, and the sequence of chemotherapy for the treatment of these patients. A study was conducted by us by showing the impact of perioperative systemic chemotherapy on patients who have diffuse malignant peritoneal mesothelioma and identified the subgroups of patients who would benefit from chemotherapy before or after CRS HIPEC. We also studied the prognostic factors and that determined helped to establish the guidelines for these patients. Methodology section has been previously described. We had 10 main topics to discuss. In the results section, diagnosis and molecular markers. So in a case of suspected peritoneal mesothelioma, what would be the preferred way of obtaining a tissue diagnosis? So the majority consensus was to obtain through image guided biopsy from omentum or peritoneal deposit along with the fluid cytology. What are the information required before starting the treatment? So we needed information of two main things, that is histological subtype and the Ki67 proliferative index.
Hello.
Go ahead, Amrish.
Yeah, can you hear me? Did it stop scaring? Hello, is the
Yeah, it's not moving.
not moving? Oh, okay, fine. Sorry. So Ki67, does it have an impact on the treatment plan? So yes, systemic chemotherapy should be preferred for patients who are Ki67 of more than 9% and a PCI of more than 17.
So is there a cutoff for Ki67 over which CRS HIPEC should not be considered even after systemic therapy? So the majority consensus was no, it can be offered irrespective of the Ki67 levels. What is the relevance of tumor markers in a case of peritoneal mesothelioma? So we did not obtain a consensus. However, the majority of the panelists voted that these could be done, but they are not mandatory. Imaging and preoperative workup. Again, what cross-sectional imaging could be recommended for patients for preoperative staging in case of histologically confirmed patients of peritoneal mesothelioma? Again, a consensus was not obtained. However, majority of the panelists voted for CT of the thorax, abdomen, and pelvis. What are the radiological parameters to indicate suboptimal cytoreduction, which in turn determine unresectability in a case of peritoneal mesothelioma? So the main factors that determined were diffuse contraction of small bowel mesentery, unilateral or bilateral hydronephrosis or involvement of the trigone, and infiltration of the porta hepatis. So is there any role of laparoscopy for peritoneal mesothelioma? So the majority consensus was yes, there is a role in selected patients. Coming to cytoreductive surgery with HIPEC and its indications. Should CRS HIPEC be considered as the standard of care for patients who are fit and completely resectable and do not have any contraindications? So yes, 100% of the panelists agreed. The extent of peritonectomy, irrespective of disease status and extent, should be total parietal peritonectomy with greater and lesser omentectomy. Which of the following organs could be resected to obtain a complete cytoreduction? So the majority of the panelists voted for spleen, distal pancreas, subtotal gastrectomy, or subtotal or segmental colectomy, or total colectomy, or multiple small bowel resection anastomosis up to 3. The contraindications for cytoreductive surgery in HIPEC in a diagnosed case of diffuse malignant mesothelioma. So we obtained a consensus statement for poor performance status and high surgical risk, aggressive histopathological variants like sarcomatoid and biphasic, radiological parameters that indicate incomplete cytoreductive surgery, namely contraction of mesentery, epigastric mass more than 5 centimeters, multiple major organ resections, or multiple small bowel resections, that is more than 3 resection anastomosis or more than 1.5 meter of small bowel. Should CRS-HIPEC be offered to patients who have extra-abdominal disease? So in selected patients with unilateral pleural disease could be offered cytoreductive surgery. The role of lymphadenectomy. Should systematic lymphadenectomy be performed in DMPM patients who are undergoing CRS-HIPEC? So the majority of our panelists voted that yes, but only in regions with enlarged nodes. Which of the following lymph node stations should be addressed surgically as a part of CRS-HIPEC? No consensus was obtained. However, majority of the panelists voted for pelvic and retroperitoneal lymph nodes. Coming to HIPEC regimen, which drug regimen would be preferred for HIPEC in DMPM patients? So a cisplatin with pemetrexed or cisplatin with doxorubicin based regimen would be acceptable. Coming to perioperative systemic therapy, in patients with DMPM who are fit and completely resectable, when would neoadjuvant chemotherapy be offered? So in patients who are a PCI of more than 17 and a Ki67 of more than 9% could be offered neoadjuvant chemotherapy. Which of the following constitute high-risk features upon completion of CRS-HIPEC when the patient needs to be considered for adjuvant chemotherapy? So factors such as sarcomatoid or biphasic histology, lymph node disease, incomplete cytoreduction, Ki67 of more than 9%, and surgical PCI of more than 17 are indications for adjuvant chemotherapy. So which subgroup of patients should adjuvant chemotherapy be offered? Majority of our panelists voted that at least one patients with high-risk features, at least one high-risk features is required. Intraperitoneal chemotherapy. Should EPEC or NIPEC be offered to patients in DMPM who have undergone CRS-HIPEC with curative intent? So the consensus was not open, and the majority of the panelists voted that it could be considered in selected patients. Should bidirectional chemotherapy be used in DMPM patients? Again, we obtained a consensus that it could be, but not outside a clinical trial. What are the current indications for PIPEC? So again, a consensus was obtained that it should be used only as a palliation method of palliation for those patients who have unresectable disease. Coming to surveillance, we obtained a majority consensus that surveillance after surgery should be in the form of clinical examination, tumor markers, and biannual CCT, thorax, abdomen, pelvis. Coming to iterative surgery, would one consider iterative CRS-HIPEC in DMPM patients with peritoneal recurrences? Again, yes, in selected patients, CRS plus minus HIPEC could be considered. Palliative systemic therapy. What are the indications for palliative systemic chemotherapy? So patients who have unresectable peritoneal disease, patients with extraperitoneal disease, and those with visceral organ metastasis, or which are unfit for cytoreductive surgery, should be sent for palliation chemotherapy. Any role of oral metronomic chemotherapy? So consensus was not obtained. However, majority of the panelists voted that as a palliative treatment for those patients who are unfit for palliative chemotherapy. Any role of immunotherapy? So the majority consensus was obtained that PD-L1 and MSI testing and immunotherapy should be offered accordingly only after progression of first line of chemotherapy. So in conclusion, CRS-HIPEC is a standard of care for resectable patients who do not have any contraindications. Total parietal peritoneectomy with greater and lesser omentectomy is the standard. HIPEC with cisplatin and pemetrexed or doxorubicin. Neoadjuvant chemotherapy for patients more than Ki67 more than 9 or PCI more than 17. And adjuvant chemotherapy in patients who have at least one high-risk feature. This is an algorithm. You all would be getting an access for it. Thank you.
Thank you, Ambrish, for the presentation. We'll have a short discussion now on the two topics that were covered, that is pseudomyxoma peritoni and peritoneal mesothelioma. Professor Glehen, any comments?
Thanks. Regarding the results of the survey for these two rare peritoneal disease, it really follows the international and European recommendations that was recently published. This is probably two pathologies for which we did a very close studies and Delphi, and the question are very close than to the question that we asked to the international expert. So in these two pathologies, there is absolutely no surprise regarding the results of the Indian survey that follow the international recommendation, and it's a good thing, of course, for. So the only thing is perhaps the particularity of your country and the question regarding the referral of the patient for this rare peritoneal disease to some expert centers. I think that this is probably one big challenge that you have in your country, because for these two pathologies, it's really important that the patient should be referred in experienced centers in comparison to other peritoneal surface malignancy. And this is the most important challenge that you have now.
Okay. Thank you, Professor, for those comments. Any comments, Professor Hubner?
Yeah, I agree with Olivier that it's very reassuring that you are pretty much in line with international guidelines, because especially for those rare entities, diversity is not good. Diversity is good in society, but not if we are dealing with rare diseases, because the homogeneity of treatments increases our credibility towards medical oncologists. So this is very important, and I think if you see important deviations with regards to IBIC regimens, etc., within your community, so come up to look for open discussions, because potentially international guidelines need to be adapted, but we have to fight diversity here in order to also gain larger data sets with the same treatments. The only problem I have is either you believe in HIPEC or you don't believe in HIPEC. So and if you believe in HIPEC, which should address microscopic invisible disease, why do you fight for the last bits of peritoneum, knowing that you will leave anyways about 50 or 60% of visceral peritoneum in place? I don't see why you should do radical Indian total parietal peritonectomy, including the lesser ligamentum, if and including also mesenteric peritoneum, if those areas are not macroscopically affected. And same applies for lymph nodes. Lymph node metastases are exceedingly rare for mesothelioma, to my knowledge. So please comment on those radical peritonectomies and lymph node dissections if you believe in HIPEC, which should do the job to kill disperse tumor cells and microscopic disease. Thank you.
Okay. Thank you, Professor. I think we'll take some last comments from Dr. Sanket and go to Dr. Aditi before we proceed. And the questions from the audience probably we'll type out in the Q&A box. Yeah, Dr. Sanket.
Yeah, so thank you for the comments. My only comment is to clarify regarding the role of two-stage surgery. I think in India, we face this unique problem of very extensive disease with unfit patients. The fitness is often related to nutrition and to physical exertion. And that is where I think we are forced to do a two-stage surgery. But in most other circumstances, I think a one-stage surgery should be considered. Uh, that's at least my perception. However, open to any other comments.
And Dr. Aditi?
Yeah. Sankit, I agree with you. And the reason we put these questions was we wanted to have some starting point, that whether it could be done or not. So, but if people are voting for it, again, that means they are doing it, or at least they believe in it. When they have a case, they will think about the two-stage procedure. I also wanted to respond to Martin's comment on the extent of peritonectomy. So in this consensus, we observed a pattern that our panelists were voting for, they were strictly adhering to evidence. So this recommendation for a total parietal peritonectomy, I think, comes not from any of our data, but from the study from Milan, in which they've clearly shown survival benefit of a total parietal peritonectomy, and it is also in the SOGI guidelines. So the 2020 SOGI guidelines on mesothelioma also recommend a total parietal peritonectomy. So, that's, they were, and a lot of panelists did tell us that, do you really want me to vote? I'm not so experienced in mesothelioma. So I think in this, our general thought was to just follow the international recommendations, at the same time have something of our own. Yeah.
Great, absolutely right. That is how this was planned and it's going ahead. So we know that the showstopper will always at the last, and we definitely have some showstoppers topics to end, and we have a fantastic faculty lined up to present this. We have the most commonest organs that all of us deal with, which are going to, I know, create a lot of buzz. So starting off with gastric cancer, Dr. Aruna Prabhu, please.
So, is the screen visible?
Yeah, ma'am, please go ahead. You're audible, visible.
Yeah, thank you. So good evening, everybody, once again, and I will be talking upon the consensus on peritoneal malignancies from gastric cancer. So to get the background, as we all know, gastric cancer is an aggressive disease and greater proportion of patients present with disseminated peritoneal metastasis. Though there are various modalities of treatment employed in an attempt to improve outcome in these patients, there are no
just a moment, put it on slideshow.
Yeah, slideshow.
It's not on slideshow.
Yeah, yes, ma'am. So as we know that though there are various modalities of treatment employed to improve outcome in these patients, there are no proper guidelines for managing these patients. So as discussed in detail, the methodology, there were 24 questions which were suggested for gastric cancer, peritoneal metastasis management, and these were divided across 8 main topics. There were 47 clinicians who voted. And as we can see that there was a fairly good percentage of voting in round 1 and round 2, as well as more than 90% and 88% voting, which was 80% completion. So let us go ahead with the results, what we saw in the consensus. So regarding preoperative workup, regarding staging laparoscopy, the consensus was that a staging laparoscopy should be performed in all patients prior to starting treatment for gastric cancer. This was in around 78.9%. Regarding patients, when a staging laparoscopy has been done and no obvious peritoneal metastasis was detected, the panel voted 87% that a Lavath cytology should be obtained and evaluated before deciding the further treatment plan. regarding the role and indications for CRS. So when patients with gastric cancer are detected with peritoneal metastasis, should aggressive locoregional therapies be offered? So the panel in 70%, more than 70%, regarded as that it should be considered in selected patients in specialized centers only and after a multidisciplinary tumor board discussion. Patients who are detected with positive peritoneal cytology and no obvious peritoneal metastasis, the panel recommended that they should be treated with neoadjuvant systemic therapy followed by gastrectomy and HIPEC followed by adjuvant systemic therapy. For patients with signet ring cell histology, as we all know, this is a poor prognostic group. Still, the 84% in the panel recommended that the CRS and HIPEC can be performed in well-selected patients with low PCI and those responding to systemic chemotherapy. Regarding the selection of patients and extent of CRS and the PCI documentation, so as all questions have been seen before, this was a unanimous voting of 100%. For Sugar Baker's PCI for documenting the extent of peritoneal metastasis in patients with gastric cancer, and a PCI of less than 7 was recommended by 82% of the panel for selecting patients for a CRS for gastric peritoneal metastasis. For patients who are undergoing surgery, the distribution of peritoneal metastasis was not considered as solely responsible to influence the decision to perform CRS if the PCI was within acceptable limits and a CC0 was possible. Again, the presence of tumor nodules on small bowel mesentery was voted by 81% that it could be considered for performing CRS if the PCI is within acceptable limits and a CC0 can be achieved. Besides PCI and achieving a CC0, there were other factors which were voted by the panel to be considered as not suitable for undergoing CRS and HIPEC, and these were involvement of small bowel mesentery or small bowel with a PCI more than or equal to 3, more than or equal to 6 peritoneal sectors involvement, that is both supracolic and infracolic compartments are involved. And again, 87% actually considered signet ring cell and poorly differentiated histology as a deterrent for performing CRS and HIPEC, though as we have previously seen that this is a special category where you can consider CRS and HIPEC in well-selected patients who are responding to chemotherapy and where a CC0 is possible within a low PCI condition. Regarding the different resections that could be performed at the time of CRS for gastric cancer peritoneal metastasis, the panel voted for distal pancreatectomy, splenectomy, segmental colonic resections, hemicolectomy, non-anatomical hepatic resections, as well as small bowel resections, and was against a subtotal or a total colectomy, a pancreatic or duodenectomy, or a formal hepatic sectionectomy, considering the fact that these are patients of gastric cancer who will mostly need a subtotal or a total gastrectomy for managing the primary disease. Again, regarding the removal of Krukenberg's tumor, a consensus was not achievable, though 68% voted that it could be removed in patients with symptomatic Krukenberg's before starting the chemotherapy. Considering lymphadenectomy being performed at the time of the cytoreductive surgery, 100% of the panel voted that it should be performed as a routine, as a D2 lymphadenectomy, as we do it for a non-metastatic disease. In patients with bulky regional nodal disease, the panel voted that it should be 90% that CRS should be considered in patients who are responding to neoadjuvant therapy if other factors are favorable. Even though there is bulky regional nodal disease and they are responding to chemotherapy, CRS could be considered. Now coming to systemic therapies, patients newly diagnosed with gastric cancer peritoneal metastasis, we just were able to reach the consensus that systemic chemotherapy alone should be preferred in these patients. The various forms of intraperitoneal chemotherapy with the port system, the PIPAC, laparoscopic HIPEC in conjunction with systemic chemotherapy, however, could not get a consensus, and it was thought to be considered to be evaluated under trial settings. Surgery after neoadjuvant treatment, the consensus was to be performed after 3 to 4 cycles of chemotherapy. And regarding maintenance treatment in patients after treatment with CRS and HIPEC and systemic therapy, the panel was that it should be done only as a trial setting. Coming to intraperitoneal chemotherapies, HIPEC was voted in 89% to be performed only after a CC0 or 1 resection has been achieved. And regarding prophylactic HIPEC in patients with high risk of developing peritoneal metastasis, the 87% voted that it should not be performed outside a clinical trial setting. Regarding management of high PCI unresectable peritoneal metastasis, the consensus could not be achieved. Though 65% said that various forms of intraperitoneal chemotherapies could be considered in managing these patients. Again, the various forms of intraperitoneal chemotherapies consensus could not be achieved, though 60% voted that PIPAC can be considered in this subgroup of patients. Lastly, feeding procedures, as we all know, these patients may come with either can have real difficulties in feeding. So various options were given and no consensus could be achieved, though SEMS, self-expanding metal stents, was voted in 42%. So this is an algorithm based on the consensus that was obtained for managing gastric cancer peritoneal metastasis. And finally, to conclude, CRS and HIPEC can be performed in well-selected patients of gastric cancer peritoneal metastasis, especially PCI less than 7, but in specialized centers and after a proper multidisciplinary tumor board discussion. The important factor is to identify these patients early in the initial course of the disease so as to offer successful treatment to them. And incorporation of intraperitoneal treatments along with systemic chemotherapy needs to be evaluated under trial settings. Thank you.
Thank you, Dr. Aruna. That was a sumptuous meal of gastric cancer that we had right now. Moving on, now we'll take on to ovarian cancer. Dr. Neha Kumar is here to present on ovarian cancer. This is, I feel, probably is most looked forward to.
Sorry, just give me a moment.
The QR code will be shown after each presentations. That gives a complete detail of all the algorithms that has been presented as a last slide by all the presenters. Ma'am, please go ahead.
Yeah, I'm just having a problem in opening. Just give me 1 second. Yeah.
Take your time, ma'am.
Just stop your screen share and try it.
Okay.
Yeah. Now open it and then try the screen share.
Yeah. Is my screen visible?
Yeah, ma'am, clear. Please go on slides flow.
Yeah. Okay. So thank you very much. Batting at the tail end, I'll be presenting the consensus we achieved in advanced epithelial ovarian cancer. And I'm grateful to Dr. Aditi, Dr. Snita, and Dr. Niharika who helped us in this. So we know cytoreductive surgery is required in advanced ovarian cancers, but we need to select the right patients at the right time. And we should know when HIPEC can be given or should not be given. There are many international guidelines which are being used in India for decision-making. However, several nuances of CRS procedure itself are not addressed by these guidelines. So the goal of this consensus was to provide treatment recommendations which are not covered by the existing international guidelines and have some recommendations tailored to some country-specific problems in India. And also to have a consensus on general and technical aspects of CRS, indications of primary and interval cytoreduction, as well as indications of HIPEC in epithelial ovarian cancer. Methodology has been discussed in detail. We had 3 members in the core group, 3 in the reviewer group, and about 48 panelists, including surgical and gynecological oncologists. The discussion was divided into these subsections as displayed. We had 47 questions in the questionnaire, and overall consensus of 68% was achieved. Both in round 1 and round 2, more than 80% of the respondents completed the questionnaire. So all the respondents concurred that complete cytoreduction, the goal of cytoreductive surgery should be complete cytoreduction to no macroscopic residual disease, that is CC0. In the preoperative workup, although a consensus was not achieved and just fell short of the 70% mark, most of the respondents felt that CT contrast-enhanced CT of thorax, abdomen, and pelvis was the preferred choice to assess the disease extent and to check whether the patient is operable or not. Upper GI endoscopy and colonoscopies were performed only if clinically indicated in the presence of some GI symptoms, raised CA, CA 19.9, or a decreased CA 125 CEA ratio, or any suspicious imaging. Diagnostic laparoscopy was performed only for selected patients if the imaging findings were indeterminate to assess the operability. There are several prediction models available, like Fagoti score and the MSKCC algorithm. However, almost 80% of our panelists felt that the selection criteria for optimal cytoreduction should be individually based upon imaging findings and using staging laparoscopy in select patients. In the presence of small bowel mesenteric disease, which is reported on preoperative imaging, although a consensus was not obtained, about 66% of the respondents felt that diagnostic laparoscopy should be done to confirm operability first, followed by surgery if they were operable. Almost all the respondents felt that PCI score cutoff should not be used in advanced ovarian cancer for cytoreductive surgery, provided that the patient is optimally cytoreducible. So PCI score was not to be used if the disease is completely resectable, and we achieved a strong consensus in that. In the presence of resectable peritoneal disease with 1 to 2 sites of bowel involvement, which would require resection and anastomosis, the consensus was not achieved, but 61% of our respondents felt that primary cytoreduction could be considered. About a third of the panelists felt that only it should, only be done if complete cytoreduction can be achieved. So there are many factors which could preclude an upfront primary cytoreduction, and majority of our respondents, we had a strong consensus on this, that involvement of pancreatic head, porta hepatis, a large disease over small bowel or its mesentery, or the disease involving root of the mesentery would preclude an upfront primary cytoreduction. In addition to that, about 82% felt that pleural involvement, and about 75% felt that suprarenal para-aortic nodes would also preclude an upfront primary cytoreductive surgery. So when we asked the respondents what should be the extent of peritonectomy during primary cytoreduction, a consensus was achieved with almost 80% respondents saying that during primary cytoreduction, routine pelvic peritonectomy should be performed along with removal of any other involved peritoneum. What procedures could be incorporated as a part of primary cytoreductive surgery? So all the respondents felt that all of these procedures, as displayed in the slide, could be performed to obtain a complete cytoreduction, except a total colectomy, a total gastrectomy and a pancreatoduodenectomy, resection of parenchymal metastasis, and also small bowel mesenteric peritonectomy. So barring these procedures, almost all procedures as displayed in the slide could be done to achieve CC0, provided patient has a good general condition and CC0 is possible. So often we are faced with this question that, should the appendix be routinely removed? So we achieved a consensus, and 72% of our panelists felt that appendix should only be removed if it is involved by the tumor or inflamed. No consensus was achieved regarding routine cholecystectomy. 56% felt that it should only be removed if it is involved by the tumor or patient has cholecystitis or cholelithiasis. But about 28% felt that cholecystectomy should be done in all cases of cytoreduction for advanced epithelial ovarian cancer. In the presence of pelvic disease, often a rectal resection is required. So we achieved a consensus with 70% of the respondents saying that if there is involvement of serosa of the rectum above the peritoneal reflection, or there is involvement of its mesentery, a rectal resection should be done. And in these cases, sometimes a diverting stoma may be required. Most often, patient factors like multiple comorbidities, low albumin status is the reason for performing a diverting stoma. But sometimes, even if the anastomosis is below the peritoneal reflection, and especially now that neoadjuvant bevacizumab is being given, these cases also often promote the surgeons to do a diverting stoma. When there is extensive cytoreduction and blood loss, about 61% of the respondents felt that they would do a diverting stoma as well. We have the LION trial, which has now said that, routine pelvic and para-aortic lymphadenectomy does not improve survival. So we pose this question to our panelists as to how they would assess these enlarged and suspicious lymph nodes. And a strong consensus was achieved wherein the panelists felt that it should be based on preoperative imaging as well as intraoperative assessment by opening the peritoneum of the retroperitoneal region. 73% panelists felt that systematic lymphadenectomy should only be done if lymph nodes are enlarged or involved on preoperative imaging or intraoperative assessment. So most of our panelists did follow the results of the LION trial. There was no consensus achieved regarding whether lesser omentum should routinely be resected in cytoreductive surgery. 46% felt that it should be removed only if it is involved by tumor, but a near same fraction felt that it should be removed in all cases. So no consensus was achieved regarding this. We had a consensus on division of the hepatic bridge, and 73% felt that hepatic bridge should be divided while excising the umbilical round ligament. In advanced ovarian cancers, often we are facing a dilemma whether to give neoadjuvant chemotherapy or not. So when asked what are the scenarios where the panelists would prefer neoadjuvant chemotherapy over a primary cytoreduction, most felt that poor performance status of the patient, any preoperative evaluation, including imaging, which would preclude an optimal cytoreduction, presence of large pleural effusion, intraparenchymal liver or lung mets, or supraclavicular lymph nodes and bulky suprarenal retroperitoneal lymph nodes would favor the patient towards neoadjuvant chemotherapy. What was surprising was that about half of our respondents felt that when there is gross ascites, they would lean towards giving the patient neoadjuvant chemotherapy. So whenever neoadjuvant chemotherapy is given, although we did not achieve a consensus, about 53% of our panelists would do a biopsy from a representative lesion and send it for histopathology and immunochemistry. About 40% would do that along with the fluid cytology and cell block, but no consensus was achieved in this regard. What regions should be addressed in interval cytoreductive surgery? We are often faced with this question whether we should remove only the residual disease which is there after chemotherapy, or should we remove whatever was present before? We achieved a consensus in this that the panelists felt that all previously involved sites in stage 3C disease should be removed. However, in stage 4, we should limit our resection to the residual disease. The extent of peritonectomy should be selective and only previously involved sites should be removed. But the consensus was not achieved in this question. In the presence of pleural disease with positive pleural cytology, 80% of our voting panelists felt that neoadjuvant chemotherapy should be administered. We asked the panelists whether they would do a VATS in presence of pleural effusion. We did not achieve a consensus. About 50% felt that they would only do it for patients with positive pleural cytology or moderate and large pleural effusions, but 36% of our panelists felt that it is not indicated. Secondary cytoreduction. Now we have differing trials regarding secondary cytoreduction. The desktop trial and the Chinese trial saying that secondary cytoreduction is beneficial, but GOG 213 saying that it is not. So these are some questions which were posed regarding this section. So for initially suboptimally debulked patients, should a repeat cytoreductive surgery be done after good response to adjuvant chemotherapy? Although we did not achieve a consensus, about 69% of our panelists felt that if the patient was suboptimally debulked initially and the surgery was done by a non-expert, following chemotherapy, if the disease is completely resectable, a repeat cytoreductive surgery should be offered to these patients. Secondary cytoreduction in the case of recurrent ovarian cancer should be offered to patients who have platinum-sensitive recurrence, which is completely resectable. And we achieved a strong consensus in this regard. It should also be offered to BRCA non-mutated tumors. In the presence of ascites, should a secondary cytoreduction be done? We did not achieve a consensus, although 57% felt that in low volume ascites, if the disease is completely resectable, secondary cytoreduction can be performed. If we follow the AGO criteria, any ascites less than 500 ml is a part of the AGO criteria. And following this, if the volume of ascites is less, these patients can be offered secondary cytoreduction provided optimal cytoreduction is possible. AGO score, I-model score, and the MSK-CC criteria are available as selection criteria for predicting a complete cytoreduction. However, most of our panelists felt that a combination of all these scores along with clinico-radiological findings should be used as selection criteria for selecting a patient who will be fit for a complete cytoreduction in secondary setting. So, now we come to HIPEC. What were the indications of HIPEC? We achieved a consensus that HIPEC can be performed in high-grade serous, mucinous, endometrioid carcinomas. Consensus was not achieved for clear cell carcinomas and low-grade serous carcinomas. In the presence of interval cytoreduction, 60% of our panelists felt that HIPEC should be done in both stage 3C and stage 4A disease following neoadjuvant chemotherapy, provided optimal cytoreduction is possible and there is no extra abdominal disease. But we did not achieve a consensus in this question. When asked what were the clinical restraints for performing HIPEC in clinical practice, most of the surgeons felt that it was the financial constraints which precluded or stopped them from giving HIPEC. About a third of our voting panelists felt that if the patient does not understand the complexity of the surgery, or there is a predicted risk of complications due to comorbidities or due to extensive cytoreduction, these factors also sometimes prevented them from offering HIPEC to these patients. No upper age limit was proposed for HIPEC, provided the performance status of the patient was good and complete cytoreduction was possible. With primary cytoreduction, HIPEC should be offered only in the setting of a clinical trial. 80% of our panelists felt. However, in secondary cytoreduction surgery, HIPEC could be performed outside a clinical trial for a platinum-sensitive disease, which is cytoreducible. Now coming to a scenario where neoadjuvant bevacizumab has been given. We are now seeing patients who receive neoadjuvant bevacizumab, and we are often faced with this question whether we should offer them HIPEC or not. So we achieved a consensus with 75% of our respondents saying that we can offer them HIPEC provided bevacizumab has been omitted in the last cycle of chemotherapy. Although we did not achieve a consensus, about half of the panelists felt that the use of neoadjuvant bevacizumab, both with and without HIPEC, could increase the rates of anastomotic leaks in selected patients. The use of neoadjuvant bevacizumab is also known to increase the rate of wound complications. About 70% of the respondents felt that this would increase the rate of wound complications, including dehiscence, burst abdomen, and intracutaneous fistulas, both in the setting of with and without HIPEC. The optimal time interval between CRS plus HIPEC with the last dose of bevacizumab should be at least 6 to 8 weeks. So a gap of at least 6 to 8 weeks between bevacizumab and the cytoreductive surgery should be there. For patients who are eligible for maintenance bevacizumab, for instance, patients who were in stage 4A or had a high disease burden with low Kelm score or had only a partial biochemical response, 80% of our panelists felt that HIPEC should be performed in these patients, and we achieved a consensus in this regard. Most of our panelists are not using the Kelm score at present. The BRCA status or the HBOC status, that is the germline or the somatic mutation of BRCA, did not impact their decision to perform HIPEC. In fact, they felt that HIPEC should be offered to these patients because there is level 1 evidence, that is the Armstrong trial and other trials, which have shown survival benefit in this subset of patients with intraperitoneal chemotherapy. And we achieved a strong consensus in this regard. So coming to the conclusion, in a snapshot, these are the consensus on advanced epithelial ovarian cancer. The blue shows strong consensus, green shows consensus, that is more than 70%, and the red shows where no consensus was obtained. So in preoperative workup, a CT thorax, abdomen, pelvis should be offered. Diagnostic laparoscopy should be done for select cases. Endoscopy should be done only if there are GI symptoms or a CA or CA 19.9. No prediction model is recommended, provided the patient is cytoreducible based on radiological findings. Diagnostic laparoscopy should be done in the presence of mesenteric disease to confirm operability. No PCI cutoff is recommended, and this is a strong consensus. 1 to 2 sites of bowel involvement is not a contraindication in primary cytoreduction, provided the disease is resectable. Disease involving pancreatic head, porta hepatis, extensive small bowel cirrhosis, mesentery or root of mesentery, pleura or suprarenal para-aortic nodes would preclude an optimal primary cytoreduction. During primary cytoreduction, routine pelvic peritonectomy should be done along with removal of involved peritoneum. Appendicectomy should be done only if appendix is involved by the tumor or inflamed. Cholecystectomy if gallbladder is involved or a patient has cholecystitis, although consensus was not achieved in this question. Rectal resection in case of involvement of rectal serosa above peritoneal reflection. Diverting stoma if the patient has multiple comorbidities, the anastomosis is below the peritoneal reflection, or neoadjuvant bevacizumab has been given. Regional systematic lymphadenectomy should only be done if lymph nodes are enlarged or suspicious. Lesser omentum to be removed only if it is involved by tumor, but we had almost a 46-43% split in this question. Hepatic bridge should be routinely divided. During interval cytoreduction, all previously involved sites prior to initiation of NACT should be removed in stage 3C disease, and residual disease should be removed in stage 4. Selective peritonectomy is recommended with involved sites being removed. Secondary cytoreduction should be offered in platinum-sensitive recurrent disease, and selection criteria should be a combination of AGO score, I model score, MSK-CC criteria, and the clinico-radiological findings. With regards to indications of HIPEC should be offered during interval cytoreduction for stage 3 and stage 4A disease after NACT, provided it is amenable to complete cytoreduction and there is no extra abdominal meds. It should not be offered during primary cytoreduction outside the setting of a clinical trial. It can be performed with secondary cytoreduction in platinum-sensitive recurrence, even outside a clinical trial. It can be given to patients who have received neoadjuvant bevacizumab, provided bevacizumab was omitted in the last chemotherapy cycle, or there is a gap of 6 to 8 weeks between the last dose of bevacizumab and the CRS. It should be performed in patients who are eligible for maintenance bevacizumab, and HIPEC can be offered to patients who have a germline or a somatic BRCA mutation due to level 1 evidence for survival benefit with intraperitoneal chemotherapy. Thank you so much for your kind attention.
That shows how much love we have for ovarian cancer in India, and that is why it is so much extensive. We cannot stop talking about ovarian cancer in India, and I'm sure that everybody will put up a lot of smile for this. Thank you, Neha. That was really,
Rohit, one of the maximum extensive work on ovary cancer happened in India. The reason is we are 1.3 billion population. Number one PSM in India which undergoes CRS HIPEC. When we looked at our registry, out of almost 3,000 cases who underwent CRS HIPEC in last couple of years, 76% is for ovarian CA because of the distribution. And India has highest young population. 1.4 billion ovarian cancer is quite high, and it's just because of the sheer number of the patient. That's it. And then this is not like in Europe or US where very few center do CRS HIPEC, they get centered. In India now we have over 100 CRS HIPEC centers. Very high volume, everybody is doing. So India is a very large country. In Europe, you can fly from any end to any end in 1 hour. In India, it takes minimum 3 to 4 hours by flight or several days by train. That's why multiple centers have developed, and number one is CRS HIPEC is ovary. That's why.
Yes, absolutely said so. That is truly the passion of India now. So now moving ahead and rounding it up to where it all started off. Swapnil is back again as a last batsman to close it up. And it all started in 2000 with the first RCT coming on HIPEC. And 2 decades down the lane, we are still debating for colorectal cancer, cytoreduction, and HIPEC. So let us see what the consensus on this comes up. Swapnil, the stage is all yours.
Thank you. So I'll be quick with my presentation as it is the last one of the webinar today. The evidence for surgical treatment of colorectal peritoneal metastasis is contentious at best. There is debate regarding the sequencing of neoadjuvant treatment, which further complicates the decision making. The demographics of colorectal cancers in India is very different. We have younger patients, we have more signet ring cell cancers, there is a very low incidence of MSI, and there are higher proportion of patients with stage 4 disease, often attributable to a lack of national colorectal cancer screening program. And to add to it, none of the published international consensus on peritoneal surface malignancies have yet addressed colorectal peritoneal metastasis. So we selected 8 or 9 key areas to vote on, and we had 29 questions to vote on, and there was a good voting throughout the consensus exercise. When asked, do you treat the colorectal peritoneal metastasis with a curative intent, panelists said that they would consider treating it for selected patients only. How would you record the PCI in these patients? They would prefer using the Sugar-Baker's PCI system. They said that the PCI cutoff as well a disease distribution both needs to be considered. However, they could not reach a consensus on what PCI cutoff to be used. When talking about other factors to be considered when selecting the patients, both the histological differentiation of the tumor as well as the presence of liver metastasis, both of these would affect the decision making regarding the PCI cutoff. Should CRS-HIPEC be offered to patients with signet ring cell cancers? And the panelists were more liberal in voting for them and said that those signet ring cell cancers with low PCI distribution and responsive to neoadjuvant chemotherapy could be considered for a curative treatment. Should the sidedness of the colorectal cancer affect the patient selection? No, it should not be affecting the patient selection as of now. Would you perform CRS-HIPEC in a metachronous setting? Yes, it can be performed if patients and disease characteristics are favorable and there is a sufficient good disease-free interval of more than a year. With regards to the preoperative workup, we could not achieve a consensus with respect to the preferred imaging modality. When talked about PET, there was a consensus in that the PET should be used only in selected patients, and specifically asking more about the PET scan. A very common indication which everyone agreed upon was the presence of any other metastatic site in addition to colorectal peritoneal metastasis should be an indication of PET scan before considering a curative treatment. Staging laparoscopy at the baseline for disease mapping did not achieve a consensus for colorectal peritoneal metastasis. Moving on to the section on systemic therapy. For neoadjuvant setting, when asked about indications of neoadjuvant chemotherapy for resectable colorectal peritoneal metastasis, the panelists voted in using it for selected patients, especially those with poor prognostic factors. When asked, would you consider performing CRS in an upfront setting? Yes, it could be considered either for those incidentally detected limited peritoneal metastasis during the surgery for the primary tumor or in those patients with limited PCI. Regarding the role of adjuvant systemic chemotherapy after curative treatment, everyone was in sync and nearly 90% said that it should be considered for patients all the patients after a curative treatment. Should CRS be performed for colorectal peritoneal metastasis in the presence of asynchronous liver metastasis? And panelists did say that yes, it may be considered in patients with a limited liver metastasis and limited peritoneal metastasis after giving initial neoadjuvant systemic therapy. And should patients with peritoneal disease and ovarian metastasis, what should be the most appropriate surgical strategy? And panelists were again having a strong consensus and saying that NSAT followed by cytoreductive surgery would be the best strategy to go for, barring those large or symptomatic ovarian masses which may be considered for resection prior to initiating the neoadjuvant chemotherapy. When delving into the molecular profile of these tumors, should BRAF mutations, mutated tumors with resectable disease be considered for CRS? Yes, they could be considered after neoadjuvant chemotherapy considering their poor prognosis. Should KRAS mutations have any bearing on the treatment schema? Everyone said that it should not have a bearing in the change of management. And should MSI testing be performed before initiating the treatment for colorectal peritoneal metastasis? And yes, panelists voted in favor of it. With the use of prognostic scoring systems, there was ambiguity and we could not achieve a consensus. And when specifically asked about the available prognostic scoring systems like the Bioscope, Compass, or the Peritoneal Severity Disease Scoring System, we could not achieve a consensus again. And majority felt that these have not been validated in the Indian population as of now. With regards to intraperitoneal chemotherapy, HIPEC, and other modalities, would you adopt the SOGI recommendations on HIPEC regimens in your practice? So this is just to reiterate that when the voting was initiated, the results had yet not been published, but were widely available through the webinars. And though we could not achieve a consensus, majority were inclining towards adopting these recommendations. Should HIPEC be offered to patients with peritoneal metastasis outside clinical trials after a CC0 cytoreduction? And yes, we could achieve a consensus for those with intermediate PCI 11 to 15. What is the current role of EPIC in patients with colorectal peritoneal metastasis? And panelists said that it can be evaluated in addition to CRS in a clinical trial setting only. The current indications of PIPAC in the treatment of colorectal peritoneal metastasis could be for those patients who have disease progression after multiple lines of systemic therapy, or also for those symptomatic patients with intractable ascites as an off-label indication. What would be the current treatment option for those patients who are newly diagnosed and are asymptomatic with unresectable peritoneal metastasis, but a good performance status? Everyone or most of them suggested using systemic chemotherapy with or without targeted or immunotherapy based on the molecular profile. With regards to the use of prophylactic treatment strategies for colorectal peritoneal metastasis, panelists voted in favor of using it, considering using it only in the context of clinical trials. And at this time point of voting, the results of HIPEC T4 were also not published as of then. And with regards to the last end of our section, colorectal peritoneal metastasis, what specific cancer-specific investigation would you perform after having treated a patient with colorectal peritoneal metastasis with cytoreduction and or HIPEC? Panelists agreed to performing a physical examination, tumor markers with a contrast-enhanced CT scan and occasional use of PET CT scan as indicated. So this is a treatment algorithm which is available on scanning of the QR code, which was generated after the results of our consensus exercise. And just to conclude briefly, that cytoreduction is widely accepted by our panelists as a therapeutic option for selected patients with colorectal peritoneal metastasis. They were more laboring in offering cytoreduction for signet ring cell cancers, even those with liver-limited disease. The recommendations on the use of various forms of intraperitoneal chemotherapy were more stringent. The use of systemic chemotherapy was recommended unanimously for most of the patients undergoing the cytoreduction, either in the neoadjuvant or adjuvant setting. So with this, I would like to conclude my presentation. Thank you.
Thank you,
Swapnil. Swapnil, I think there is one slide probably you didn't elaborate. When the question was asked if CRS or without HIPEC is not an option, what are the most common? The most common response there was concomitant IV chemo with the PIPAC. 65% of the people actually did. It's a very high. So that's one of the common, and 63% was other form of IV. That's one of the long bar chart. So we didn't probably, frame the question more towards that since evidence was picking up in PIPAC. Yeah. We can elaborate in the publication when we do about this particular bar chart.
Okay. Thank you, Swapnil. So we have come to the end of the presentations of the 8 subtopics that we had at the consensus. Now coming for the final comments from our experts, Professor Glehen.
Yes, so as conclusion, first, I would like to really once more congratulate not only the presenters for a perfect presentation, but also all the groups that builded the question because it was big work, and I found all the questions very interesting in every etiology. So once more, congratulations. To speak first about gastric cancer, there is two things I think that could be modified. The first is regarding the completeness of cytoreductive surgery. Perhaps in some disease we can tolerate a CC1, but I don't think that we can tolerate a CC1 in gastric cancer if we want to get the better results. So this is my first comment. My second comment is regarding the PCI. It's practical to say, okay, we will use the cutoff of PCI less than 7. But I think that the cutoff of the PCI in this pathology should be decided according to the pathology. Less than 7, certainly for poorly differentiated tumor. But I think that we can use a higher PCI for less common today pathology. But when you do not have this poor pathologic condition, the results, especially in France, showed that you can get very good results even with a PCI between 7 and 13. Your survey underlined the fact that probably we should move to a bidirectional therapy in established peritoneal metastasis non-resectable, combining intravenous and intraperitoneal. But the modality of this intraperitoneal chemotherapy is still debated. And probably that in the future we should work on defining the best regular long-term intraperitoneal chemotherapy without hyperthermia, as they are performing in the Asiatic countries, PPAC or laparoscopic IPEC. And I think that it will be one of the challenges that we have in the next years to try to pick up the winner between all these modalities and to try to compare these modalities. It's a big challenge because regarding the countries, there is a lot of difference, but we should try to evaluate, to compare. And I think that the next international trials that will be conducted by Jimmy So regarding conversion surgery, but that will register the patients treated by this bidirectional chemotherapy will give us some answer. Regarding ovarian cancer, I think that I do not have anything to add, except maybe for the lymphadenectomy. Maybe as you know, there is another randomized controlled study that was presented in the ASCO meeting that showed that the systematic lymphadenectomy should be abandoned because it does not add anything to the survival. It was a Caraco study that was presented by Jean-Marc Claes once more. I was really surprised that IPEC was not recommended as procedure combining to CRA in interval cytoreductive surgery, because I think that into the literature we have more level 1 evidence in the demonstration of the benefit of IPEC in this setting than in the recurrent setting, for which we have only one randomized control trial. So I was surprised about this. And
I'll interrupt you. It was for 4A. We did not agree for stage 4A. But I think we got a consensus for 3C. Sorry.
Okay. Okay. And we still have a lot of work to push you to use the Kelim score that I think it's this Lyon score is really useful to choose the adequate sequence in the first line and also in the recurrent setting. It really determines with accuracy the patients that are chemosensitive and the patients that are not. And I think that for the selection, it demonstrated in every randomized trials, prospectively and retrospectively, that it should be a useful score that should be used. So we have a lot of work. And regarding colorectal disease, of course, you do not follow the recommendation, the international recommendation of the PSOGI and Big RENAP. The use of IPEC is still really debated, probably because this IPEC should be used in selected patients, not only in patients with PCI between 11 and 16. I think that there is many way to follow. It could be organoid, it could be liquid biopsy to determine the patient that is at risk of systemic disease and at risk of local regional disease. I'm okay with you with the fact that we do not have sufficient level 1 evidence. But when you look, for example, at the last registry that was published in the BGS, I think, of more than 2,000 or 3,000 patients, it shows that IPEC intensification did better than regular IPEC. So this is the demonstration that probably IPEC is working. But I'm okay with you that IPEC with mitomycin alone is not an exciting procedure. So I think that in the future, if we want to really improve the prognosis of patients with peritoneal metastasis, we should continue to evaluate IPEC and select the appropriate patient that could benefit of IPEC. Otherwise, we will have appropriate results with cytoreductive surgery alone, but we will not gain, as we gained in the past, 10 months of median survival every 10 years. This is my comment.
Okay. Thank you, Professor. And any last words from Professor Hogner?
Yeah, my friend Dr. Roit texted me, you are listening like an obedient student, and he's right, in fact, because it was extremely interesting session, and I learned a lot. So a couple of comments. What was reported now are mainly your intentions or your assumptions, what you are doing, and I think it would be very interesting to do a cross-sectional study over 3 months to actually observe your practice and to compare them with intention, because we saw it for many guidelines that the compliance with guidelines or the compliance with your institutional intentions is not at all the same. So this is one remark. Second, for colorectal selection, 11 to 15, I don't need to explain you that this was for a oxaliplatin-based IPEC, which has been abandoned, and I would argue with you that you would probably IPEC a young patient in good state, non-mutated with a PCI of 16, but probably you should consider not to IPEC a BRAF mutated multimorbid patient. So I think selection of patients is key for surgery, but also for IPEC. Then the different IP chemotherapies, pick the winner. I'm not sure, and I think we should abandon the comparing one against the other, but really more investigating different sequences of treatment. And I share Olivier's opinion that the pragmatic trial of Jimmy-So is brilliant, because we just say we don't include all types of different induction treatments, be it combined or not, and you choose your type of IP treatment you want to have. And then we see if it's worth to go for a resection, number one, and maybe with the data we can also see which treatment for this setting for gastric cancer might be the same. So I think large registries and pragmatic trials will help. What else? I think that's enough. We are all tired. Thanks very much. Congratulations.
Dr. Sanket?
Yeah, thank you, Dr. Hubner and Dr. Glenn, for all your comments. I think that sums up most of the things. I will just add a couple of things. One is that the ovarian cancer results pretty much reflect the diversity of the country, available expertise, and I think a lot of things here in the registry will be of value to all the practitioners. Yes, it depends upon us to make sure that this consensus is, dispersed and followed. Secondly, regarding gastric cancer, I think we will see a lot of changes with the upcoming rules of intraperitoneal chemotherapy, including PIPAC and laparoscopic HIPAC. And regarding colorectal cancer, I think most of the things have been summed up by the previous two speakers. I still feel that in India, where cost is a significant consideration, good CRS is very, very important, and probably the single most important factor when it comes to colorectal cancer. In a country where people struggle to pay for chemotherapy and targeted therapies, whether a HIPEC really adds in this scenario, where you would probably see greater benefit from targeted therapies, is really something we need to consider when we are selecting the option. And I'm sure all the people involved are bearing this in mind when they voted for these questions. And thank you, everybody. Last but not the least, I would like to thank all the people who have put in all the hard work, and Aditi for steering this entire consensus. Fantastic work, everybody. And we should continue building on what we have done in this consensus. Thank you.
Dr. Aditi?
Yeah, so I'll not take much time, just a quick comment. Regarding PIPAC, we have mass certification of PIPAC now. Just recently, 100 people were certified, and there are 100 others in the waiting list. And most of these people are not even experienced in the management of peritoneal metastasis. So we had to have some recommendations about it. Every other day, we have questions on our group. Like yesterday, it's CAGB with ovarian met. Should we do PIPAC for that patient? So we had to again have a starting point. And regarding colorectal PM, unfortunately, HIPEC is a long shot. We are not getting reference for CRS anymore. After Prodige 7, a lot of our medical oncologists have just stopped referring patients for CRS also. We see so many young patients who are just put on chemotherapy for 1.5 years, 2 years, with clearly resectable disease with good performance status. So, if the HIPEC recommendations are not so in line with the SOCI recommendations, it's okay. We are happy that at least everybody strongly recommended CRS. Thank you.
Thank you. Thank you, ma'am. Now, just for the closing remarks, I would like to invite Professor Ramakrishnan, and I can't think of anyone better to invite for closing remarks, because he's someone we look forward to for feedback, and the way he puts forward points with clarity is just something we look forward to. Yes, sir.
Thank you, Vivek. I think firstly, I must congratulate myself for having answered 200 plus questions. It was really a laborious task, and I had faced so much difficulty in answering the questions. I know the difficulty that the entire team would have gone through in putting together this whole show. a big congratulations for all the great effort taken by Aditi and all the other young members of this concern. And this again brings me to point that we are fortunate enough to have such a brilliant group of young second generation surgical oncologists who have special interests in peritoneal surface malignancy. So I think the future of peritoneal malignancy in India, treatment of peritoneal malignancy in India is very bright. From both the groups, we have huge talent, huge pool of talent, and I hope we are able to leverage this pool of talent in the right. And would welcome any advice from Lehen and on how to channelize this energy create. So I'm not going into any specific comments. The next step would be publishing the results of this consensus, and I think some work is already underway. 2 manuscripts have been written on the general methodology and the colorectal cancer, and if I'm not mistaken, I think and soon for review by an international journal. So I hope we are able to publicize the efforts of this work and encourage other countries also to take part in this. And finally, I would again like to caution all the participants who are listening in to this that this should not be treated as a recommendation. These are a consensus statement, or probably call it a survey among group of peritoneal surface surgeons in India, and it should be treated as such. These are just our experience of what we do day in and day out. We might be correct in many of the things, we might not be correct, but there are no straightforward black and white answers to many of the questions that have been asked here. So I think probably that serves the purpose of this kind of census attempt, because field of peritoneal surface oncology, India has exploded the past decade. Everybody wants to get in on this bus. Naturally, there would be a lot of questions asked about what we should do in the situation. And as was initially pointed out, there are no answers to some of these anywhere in the literature. I mean, everybody has his own or her way of doing this. This is what we arrived at a consensus. I hope everybody understands that this should be not as a recommendation. Thank you once again, Professor Behen and Pugna, for graciously spending so much time and giving your experts comment. Also, I would like to thank Aditi, Somashekar, and everybody else who have played a tremendous role in putting together this whole conference. Thank you once again. And